Hey everyone, and welcome to this high-yield explainer. We're about to break down the absolute must-know respiratory concepts to help you walk into the NCLEX and completely crush it. We're going to focus on the patterns, the priorities, and of course those classic traps the exam just loves to use. Let's get you feeling confident and prepared. So, let's start with the most fundamental truth in all of patient care. Seriously, this isn't just some catchy phrase to remember. It's the core principle that drives every single decision you're going to make. If you don't have adequate oxygenation, every other system in the body just starts to shut down.
That's right, we're talking about breathing, the B in airway breathing circulation. For the NCLEX and for being a safe nurse, mastering this is completely non-negotiable. So let's dive right in with the absolute foundation, the oxygenation imperative.
First things first, we have to get crystal clear on the basics. How does oxygen get from the air we breathe all the way into the body's tissues? This is the bedrock for everything else we're going to talk about. Okay, it is absolutely crucial that you know the difference between these two. Ventilation, that's just the mechanics. It's the body's bellows, moving air in and out. But oxygenation, that's where the magic really happens. That's the actual exchange of gases that keeps our patients alive. And here's the key. A patient can be ventilating just fine, but not actually oxygenating.
And this is where it all goes down. The alveoli, these tiny little air sacs in the lungs. Think of them like microscopic bunches of grapes. They're the functional units for gas exchange. This is the exact spot where oxygen crosses over into the bloodstream and carbon dioxide crosses out so we can get rid of it.
All right, let's get practical. Let's talk about what you do the moment you walk into a patient's room. Because this is how most NCLEX questions are going to start, right? They drop you into a clinical scenario. And in that moment, your initial assessment is everything.
So listen, the crucial point here is that you have to assess and act in this exact order. You can't fix breathing if the airway is blocked. It's that simple. And that high-pitched, awful sound of stridor, that's a code-level emergency. It trumps a low O2 sat, it trumps low blood pressure, it trumps everything. It's always airway, then breathing, then circulation, period.
Your assessment has to be systematic, every single time. It's simple, really. You look, you listen, and then you check the vitals. Following the sequence, make sure you don't miss any of those critical clues.
First, just look at your patient. You can see a lot from the doorway. Are they fighting for their breath? Can you actually see the muscles in their neck or between their ribs pulling with every inhale? Are they leaning forward in that classic tripod position, trying to create more space to breathe? These visual cues are huge red flags for dyspnea, and you can bet they are extremely testable.
Listen, if you remember just one thing about visual signs, make it this. Restlessness, a little bit of irritability, maybe some new confusion, those are early signs of hypoxia. The brain is so sensitive to low oxygen. Cyanosis, that bluish color in the skin, that is a very, very late sign. If you wait for your patient to turn blue, you have waited way too long.
Next up, you listen. Now this table is so important because the NCLEX won't just say the patient has stridor. No, it's going to describe the sound. So if you read a high-pitched sound on inspiration, your brain needs to scream stridor, upper airway obstruction, emergency. Same thing for a musical sound on expiration. That's wheezing. Popping sounds, that's crackles. Get familiar with the descriptions.
And finally, we get to the vitals. Here's a classic NCLEX-style question. They give you a set of vitals and ask, which one is the biggest red flag, the earliest sign of a problem? So which one do you think changes first when a patient is getting hypoxic?
The answer, almost every time, is respiratory rate. The body's first, most immediate instinct when it senses low oxygen is to try and get more air. And how does it do that? It starts breathing faster. Tachypnea is so often your very first clue that something is going wrong.
Okay, so you've done your assessment and you've decided your patient needs oxygen. Great, but what do you do next? The key is choosing the right delivery device. And I want you to think about this like you're climbing a ladder.
You always start with the least invasive option that's going to get the job done. For someone with just mild hypoxia, a nasal cannula is perfect. But as their needs get bigger, you climb that ladder. You go to a simple mask, maybe a more specialized mask, and then for severe hypoxia, you go to the non-rebreather. Trust me, the NCLEX loves to test whether you know when to go up or down this ladder.
And here's a crucial point. The non-rebreather mask is the top of the ladder for just giving simple oxygen flow. If your patient is on one and they're still struggling, it means they need more than just oxygen. They need pressure to help open up their lungs. And that means you're escalating to things like BiPAP or even getting ready for intubation.
All right, let's quickly talk about arterial blood gases.
Look, for the NCLEX, you do not need to be an ABG expert, but you absolutely have to be able to recognize the basic patterns, especially the respiratory ones. Here's the simplified version you need for the exam. Just look at the relationship between CO2 and pH. If they're moving in opposite directions, like one's high and the other's low, you should immediately think respiratory. High CO2 with a low pH, they're not blowing off enough CO2 and they're acidotic. Low CO2 with a high pH, they're blowing off way too much and they're alkalotic.
This is your money phrase. In an ABG question, if the PaCO2 is the number that's out of whack and it explains the change in the pH, you're dealing with a respiratory issue. It's really that simple. Find the CO2 and see if it's the culprit.
Okay, time to bring it all home. Let's put everything we've talked about into a rapid-fire strategy you can use on test day to crush any respiratory question that they throw at you.
So when you see a respiratory question, this is your mental checklist. Before you even peek at the answers, ask yourself, is the airway open? Is the breathing good enough? Is this an early sign I can fix or a late sign that's a full-blown emergency? If you frame every single question through the lens of how do I get oxygen to the tissues, the right answer often just pops out at you.
Okay, let's put this into practice right now. You walk in, you see this patient. They're breathing fast, they're not thinking clearly, and their O2 sat is dropping even though they're on oxygen. What is the very first thing you are going to do?
You have to act. That nasal cannula just isn't cutting it anymore. The new confusion is a massive red flag for worsening hypoxemia. Your priority is to get them more oxygen, but to do it precisely with a Venturi mask because of their COPD history, and then you immediately get on the phone to the provider about the change in their condition. It's a classic case of intervene first, then report.
And we'll end with this question for you to think about. What is that one sign, that subtle change in their mental status, that little bit of restlessness that you will now be able to spot from a mile away? Because your ability to recognize that early sign of trouble, that's what makes you a safe, effective, and NCLEX passing nurse.
We're going to explore the disorders that either fill our lungs with gunk or squeeze them so tight they just can't expand. Okay, so before we get into everything that can go wrong, we've got to appreciate what right looks like. And it all comes down to these millions of tiny, tiny air sacs in our lungs called alveoli. Seriously, just picture these microscopic balloons where all the magic happens. Oxygen comes in, hops over into the bloodstream, and the waste product, carbon dioxide, hops out so you can exhale it away. It's this beautiful, elegant exchange that literally powers our entire body.
Now here's the thing. When you really get down to it, pretty much every major respiratory crisis boils down to one of two fundamental issues. First, you've got the filling problem. This is where those critical alveoli get clogged up with fluid or pus or just inflammatory junk. It creates a physical barrier that stops oxygen in its tracks. Or, second, you have the squeezing problem. This is when something, anything, is preventing the lungs from fully expanding in the first place.
So here's our game plan for today. We're going to start by tackling the conditions that fill up the lungs. We're talking pneumonia, the very unique case of TB, and the all-out crisis of ARDS. Then we'll pivot and look at what happens when lungs just can't expand, and we'll wrap it all up with the key interventions that nurses use to guard that airway and fight back. Let's get into it.
Okay, first up, the filling problem. This is where the real battle takes place, right inside those tiny air sacs, as infection and inflammation try to take over.
Pneumonia is the absolute classic example of a filling problem. Some kind of germ, whether it's a bacteria, a virus, or a fungus, invades the lung tissue. And your body, of course, sends in the troops, its immune cells, to fight. The battlefield, the alveoli, and they get totally flooded with inflammatory fluid and the debris from the fight. All of a sudden, the very space that's supposed to be for air is just occupied. And the consequences of that are immediate. Gas exchange just tanks, which leads to low oxygen in the blood or hypoxia. Now here's something you have to remember. One of the earliest signs of that hypoxia, especially in older adults, can actually be confusion or agitation. Of course, you get the classic fever and a productive cough, but for a nurse, the key clinical clue is what they hear through a stethoscope, a sound called crackles. It's literally the sound of air trying to bubble through those fluid-filled sacs.
So how do we fight back, especially after surgery when patients are often immobile and breathing really shallowly? Well, we use this surprisingly simple device. The incentive spirometer is basically a workout for the lungs. By taking a slow, deep breath in, the patient forces those vulnerable little alveoli to pop open and stay open. It's all about preventing them from collapsing, a condition we call atelectasis.
All right, let's move on to a much more specialized kind of invader, tuberculosis, or TB. It is another filling problem, but believe me, it has a very different strategy. This is an infection that the body actually tries to wall off.
You see, the TB bacterium absolutely loves oxygen, which is why it usually sets up shop in the upper parts of the lungs where there's plenty of air. In response, the body's immune system surrounds the bacteria, forming these hard little nodules called granulomas. It's essentially trying to build a fortress around the enemy to keep it contained.
Now, this is where it gets really important to understand the difference between latent TB and active TB. In latent TB, that fortress is holding strong. The body has successfully contained the bacteria. The person is infected, sure, but they aren't sick, and, this is crucial, they are not contagious. But if their immune system weakens, that fortress can break down, the bacteria are released, and it transitions to active TB. Now they've got symptoms, and they are highly contagious.
And because active TB is spread through the air, the precautions are incredibly strict. And for good reason. Unlike bigger droplets from a cough that just fall to the ground, these tiny TB bacteria can just hang suspended in the air for hours. That's why healthcare staff need a special N95 respirator, and the patient has to be in a negative pressure room that constantly vents air to the outside.
Okay, now we move to the most catastrophic filling problem there is, acute respiratory distress syndrome, or ARDS. This isn't just a localized infection. This is a massive, system-wide inflammatory response that just completely floods the lungs.
And the absolute key to understanding ARDS, the one thing you have to remember, lies in one hallmark sign. This one concept defines the entire crisis.
It's called refractory hypoxemia. Here's what it means. You can put the patient on 100% oxygen, just crank it up, but their blood oxygen levels won't improve. Why? Because the problem isn't a lack of oxygen in the air, it's a physical barrier. The alveoli are so filled with inflammatory fluid that oxygen literally cannot get across into the blood. It's like a total supply chain crisis right at the molecular level.
This mnemonic actually sums up the whole cascade of failure in ARDS perfectly. The A is for atelectasis, that widespread collapse of the alveoli. R stands for that hallmark refractory hypoxemia. D is for decreased lung compliance, meaning the lungs get super stiff and hard to inflate. And S is for the surfactant cells being damaged, which is what kicks this whole vicious cycle off.
Okay, let's pivot. We've talked a lot about what happens when the lungs fill up. Now, what happens when they can't even expand properly in the first place? This is the squeezing problem.
The sounds of breathing really tell a story here. I mean, it's a key clue. If you hear crackles, you're hearing air bubbling through fluid that's inside the alveoli. That's a filling problem. But what if you hear very little sound or even nothing at all? Well, that tells you that air isn't even getting into that part of the lung. It's either collapsed or it's being squeezed from the outside.
We've mentioned atelectasis a couple of times. This is that internal collapse of the air sacs. It's exactly why postoperative patients are at such a high risk, and it is precisely what that incentive spirometer is designed to prevent. It's all about reinflating those collapsed little sections of the lung. And there are other ways lungs get restricted. With a pleural effusion, fluid builds up on the outside of the lung, in that space between the lung and the chest wall, and it physically squeezes it. Then you have something like pulmonary fibrosis, where the lung tissue itself becomes all scarred and stiff. It loses its natural elasticity, its ability to expand. Both are squeezing problems, just with different causes.
So, we've seen the enemy in its two main forms, filling and squeezing. Now, how do we fight back? Let's talk about the key nursing interventions for guarding that all-important airway.
You know, whether the problem is filling or squeezing, these priorities are pretty much universal. Positioning is critical. Just sitting the patient up makes breathing easier. And a cool little trick is positioning them with their healthy, good lung down. That actually uses gravity to improve oxygenation. Of course, we constantly monitor oxygen levels, we actively work to clear secretions, and we implement the right infection control. But honestly, most importantly, we monitor relentlessly for any little change.
Which really brings us to our final thought. With all the amazing technology and treatments we have in this constant, fundamental battle for every single breath, what do you think is the most powerful tool a clinician really has? Is it a ventilator, an antibiotic, or is it sharp assessment skills, critical thinking, and just the ability to see and hear the clues the body is giving you?
All right, welcome to the Explainer. Listen, if you're heading the books for the NCLEX, you just know you're going to see questions on asthma and COPD. They're everywhere, but they're also super easy to get twisted. So today, we're going to lock this down. We're going to make sure you can nail the difference every single time.
And let's get real for a second. This is so much more than just passing a test, right? This is about that moment when your patient can't breathe and you need to know exactly what to do. The stuff we're covering today, it directly translates to life or death decisions you'll make at the bedside.
Okay, so here's our game plan. First, we'll look at the big thing they have in common, that airway obstruction. Then we're going to dig into the nitty-gritty science, the pathophysiology that makes them totally different. After that, we'll cover what you'll actually see in your assessment, the all-important medication plan, and then the big one. We'll break down those tricky priority traps that the NCLEX just loves to throw at you. All right, first things first, let's get on the same page. Both asthma and COPD are what we call obstructive lung diseases. And here's the key thing to get. The problem isn't getting air in. Nope. The real struggle is getting the air out. I want you to imagine trying to breathe out through one of those little coffee stir straws. See how hard that is? That's the resistance we're talking about, and it causes all this old, stale air to get trapped inside the lungs. Okay, if you remember one word for asthma, let it be this: reversible. Seriously, tattoo it on your brain. Think of it like a temporary freakout by the airways. You've got inflammation, you've got mucus, you've got the airways clamping down. But it comes and it goes. It's usually kicked off by a trigger, like dust or cold air. But the beautiful thing is, with the right treatment, those airways can go right back to normal. And now for COPD. The P word is the polar opposite, irreversible. This isn't just a bad day for the lungs. This isn't a temporary flare-up. We're talking about permanent physical damage. The structures, the little air sacs and airways, are actually destroyed. And this usually happens over a long, long time from stuff like smoking. So we've got these two big ideas, reversible versus irreversible. But how does that actually play out inside the body? Well, that brings us to the pathophysiology. This is the why. It's the science that explains literally everything else we're about to talk about. Okay, let's really break this down. For asthma, you've basically got these super sensitive, hyper-responsive airways. They just overreact to everything. It's like they have zero chill. Now, with COPD, it's usually a double whammy. You've got emphysema, which is just tearing down the walls of the tiny air sacs, and you've got chronic bronchitis, which means the airways are just constantly inflamed and full of gunk. This here really shows what happens in asthma. So, a trigger, let's say pollen gets in. The body's immune system sees it and goes into full-on panic mode. It unleashes this chemical flood that causes a total triple threat. First, the muscles around the airways squeeze tight. Second, the lining inside the airway swells up. And third, the body starts pumping out tons of thick, sticky mucus. All three of those things choke off the airway. But, and this is the key, with the right meds, we can tell the body to calm down and reverse the whole process. Okay, so we've got the why down. We know what's happening on the inside. But what are you going to see when you walk into that patient's room? What are you going to hear? Let's talk assessment and how to read the signs of someone in real trouble. Now, a lot of the classic signs pop up in both diseases, so you got to be sharp. You'll hear wheezing. That's that high-pitched, almost musical whistling sound. That is literally the sound of air trying to squeeze through a tiny, narrowed tube. And watch their breathing pattern. You'll notice it takes them forever to breathe out. That's called a prolonged expiratory phase. They are fighting to push every last bit of that trapped air out. Now, this next one is a classic, but it's something that takes years to develop, and it's a huge signpost for emphysema-dominant COPD. Think about it. All that air is trapped, day in and day out. The lungs are constantly hyperinflated, kind of like a balloon that's always full. Over time, that constant pressure actually changes the shape of the chest, pushing the ribcage out. And that's how you get that classic rounded barrel chest. Okay, listen up, because this is huge. If you walk into a patient's room and you see them sitting like this, your alarm bells should be going off. This is the tripod position, and it's a giant flashing red light for severe respiratory distress. It's not a choice, it's instinct. They're leaning forward, planting their hands, trying to use every single muscle they have, in their neck, their shoulders, everywhere, just to pull in one more breath. They're trying to give their lungs more space to work. Now, this is super interesting because it's both a sign that they're in distress, but it's also a really smart coping mechanism. It's called pursed lip breathing. What they're doing is creating back pressure by breathing out slowly against their tightened lips. It's like they're creating their own little bit of PEEP, positive end expiratory pressure. And that back pressure acts like a splint, popping open those floppy, collapsed airways just long enough to let more of that trapped, stale air get out. It's something you'll actually teach your patients to do.
Understanding this difference is key to figuring out why some patients get better with oxygen and others don't. Think of it like this. With a shunt, like a pneumonia, the road is open, but it's completely flooded with junk, so the air can't get through. With dead space, like in a PE, the road is clear, but a giant roadblock, a clot, is preventing any cars or blood from getting there. This is a classic safety question. For some COPD patients who retain CO2, their body's main trigger to breathe isn't high carbon dioxide anymore. It's low oxygen. So if you blast them with too much O2, you can actually suppress their drive to breathe. For these patients, precision is absolutely everything.
And the answer is the Venturi mask. For the NCLEX, here's your takeaway. When you see the words precise FiO2, especially for a COPD patient, your brain needs to immediately go to Venturi mask. It's designed specifically for that job, delivering an exact, reliable oxygen percentage.
And this is a massive trap. A pulse oximeter is a great tool, but it's not foolproof. It can't tell the difference between hemoglobin carrying oxygen and hemoglobin carrying carbon monoxide. So with CO poisoning, the carbon monoxide latches onto the hemoglobin, and the machine can give you a beautiful but completely false reading of 99%, all while your patient is literally suffocating from the inside out.
All right, let's switch gears and talk about what we're going to do about it. Let's talk meds, because on the NCLEX, it's not enough to just know the names of the drugs. That's only half the game. The real test is knowing the order. The sequence is everything, and that's how you prove you're a safe nurse.
So here is the absolute #1 non-negotiable rule for inhalers. Bronchodilator before steroid, always. You have to open up the airways first. You give that SABA, your fast-acting rescuer like albuterol, before you even think about giving the long-term controller med like a steroid. The best way to think about it is this. You wouldn't try to get furniture into a room through a closed door, would you? Of course not. Albuterol is the key that unlocks and opens that door. Then, and only then, can the steroid get in to do its job. So here's your basic toolkit. Just remember the A's. Albuterol is for an acute attack. That's your SABA, your first responder drug. It's the rescue. Everything else on this list, the LABAs, the anticholinergics, the steroids, they're your maintenance crew. They're for prevention, for long-term control. They don't rescue anybody. Oh, and it's super important teaching point with those inhaled steroids. You have to tell your patient to rinse their mouth out with water after every single use. If they don't, they're setting themselves up for a nasty case of oral thrush. That's a classic NCLEX question.
Okay, buckle up. This is probably the most important part of this whole explainer. We're talking about the NCLEX priority traps. These are the questions designed to see if you can tell the difference between a patient who is just sick and a patient who is actively dying. This is where it gets real.
I really need you to let this one sink in. You have a patient with an asthma attack. They're wheezing loudly. You're giving them treatments, and then silence. The wheezing stops. Your first thought might be, great, they're getting better. No. That is a terrifying sign. A silent chest doesn't mean the airway is open. It means the airway is now closed. No air is moving at all. That patient is about to arrest. That silent chest is the hallmark of status asthmaticus. This is a full-blown medical emergency. The regular treatments aren't touching it, and your priorities have to shift like right now. This is no longer about just giving another albuterol neb. This is an airway emergency. You need to be yelling for help, slamming on high-flow oxygen, and getting ready, because that patient is probably going to need a breathing tube, and they're going to need it stat. Okay, now for the other big NCLEX trap, this one for COPD. You need to burn this number range into your memory, 88 to 92%. That's it. For a patient who has a chronic CO2 retainer, that's their happy place. That is their target SpO2, and I know, it feels totally wrong, right? It's so low, but cranking up their oxygen can actually be one of the most dangerous things you can do. So think about it like this. For you and me, the reason we take our next breath is because the CO2 levels in our blood get a little too high. That's our primary drive to breathe. But for some folks with severe COPD, they live with high CO2 levels 24/7. Their body just gets used to it and starts ignoring that signal. So it switches to its backup plan, the hypoxic drive. Their new trigger to breathe is low oxygen. So what happens if we come in and blast them with high-flow oxygen? We take away their only reason to breathe. You can literally make them stop breathing.
Okay, let's wrap this up with the ultimate cheat sheet. This is everything you need to know. Patho, asthma is reversible inflammation. COPD is irreversible damage. Onset, asthma is often younger and comes and goes. COPD is older and just gets worse. Hallmark sign, think episodic wheezing for asthma and that barrel chest for COPD. And the big scary priority traps,
For asthma, it's that deadly silent chest. For COPD, it's over-oxygenation and knocking out their hypoxic drive. You need to know this table inside and out. So let's put it all to the test. Who are you running to first? Remember your ABCs: airway, breathing, circulation. The asthma patient with a silent chest has an airway problem. It is completely closed off. The COPD patient with an O2 sat of 87% has a breathing problem. It's not great, but air is still moving. A closed airway will kill your patient in minutes. Breathing is second. Your priority is always, always, always the silent chest. Nailing that distinction, that's what makes you a safe nurse. And that's exactly what the NCLEX is testing.
We're about to break down everything you need to know about these drugs, and maybe even more importantly, how to actually use them the right way. Let's jump in.
So, when we talk about breathing problems, it almost always boils down to two main culprits. First, you've got bronchoconstriction. That's just a fancy way of saying the airways are tightening up, making it hard for air to get through. And second, you have inflammation, where those same airways get all swollen and puffy. Literally, every single drug we're going to talk about today is designed to fix one or both of these things. That's it.
And to help you remember this for your exams, we've got a super simple mnemonic. Just think of it like two teams working towards the same goal: getting air in. First up is Team BAM. These are your bronchodilators. Their job is to, BAM, open those airways right up. Then you have Team SLAM. These are the anti-inflammatories. They slam the brakes on all that swelling. So just remember, BAM and SLAM. All right, so here's the roadmap for today. We're going to start by officially meeting Team BAM, the bronchodilators, and then we'll get to know Team SLAM, the anti-inflammatories. After that, we'll cover a few other specialist drugs, and we'll wrap it all up with the really practical stuff, mastering that inhaler technique.
Okay, let's dive right in with Team BAM. Think of these guys as the first responders, the fast-acting heroes. When your patient is gasping for air and can't breathe, these are the drugs that are going to get in there and open up those airways fast.
Now, within this first group, you've got to know the difference between the two types. This is huge. First, you have the short-acting ones, your rescue inhalers, like albuterol. Just remember, A for albuterol, A for an acute attack. These are for emergencies. Then you've got the long-acting guys, like salmeterol. To remember that one, think of eating salmon for a long life. This is for long-term control. And here's a massive safety tip. You never use a long-acting inhaler for an acute attack. It's too slow and won't work.
Here's the trap. Giving a long-acting drug like salmeterol for an acute asthma attack is totally ineffective and, frankly, dangerous. It's like sending a text message when you should be calling 911. During an attack, the patient needs that airway opened immediately. The priority is always the fast-acting rescuer, albuterol.
You know, since albuterol is basically revving up the body to open the lungs, it kind of revs up everything else too. So the side effects are totally expected. And you can remember them with the 3 T's. You'll see tachycardia, that's a fast heart rate and palpitations. You'll see tremor, some shakiness. And you'll see tossing and turning at night, or insomnia. This is a key teaching point. Tell your patients to avoid taking it right before bed if they can.
All right, still on Team BAM, let's talk about the anticholinergics. You'll recognize these because they end in tropium, like hypertropium. Their main job is to dry the body out. And there's a classic nursing school rhyme to remember the side effects. Can't see, can't pee, can't spit, can't, you know. So what do you teach your patients? To drink more fluids and maybe suck on some hard candies to help with that dry mouth.
Okay, stop right here. This is a perfect summary slide for Team BAM. Seriously, grab a screenshot. You've got your beta-2 agonists ending in buterol for those brutal asthma attacks, your anticholinergics ending in tropium, the ones that dry you out, but the one you really, really have to watch out for is theophylline. Look at that tip. The safe range is tiny, just 10 to 20. If that level gets over 20, it becomes toxic, and we're talking about major, life-threatening seizures. So dangerous.
All right, Team BAM, handles the immediate crisis. But what about the underlying problem? That chronic swelling. That's where our second team comes in, Team SLAM. These drugs don't provide that instant relief. Instead, they work behind the scenes to soothe that swelling for long-term control.
So the heavy hitters on Team SLAM are the corticosteroids. You know, the ones ending in -son or -ide. There's a lot to know about them, but we can remember the big points with the S's. A few key ones to drill in for exams: they reduce swelling, but they have a very slow onset, not for rescue. They increase blood sugar, they can cause sores in the mouth, and this is critical, you must stop them slowly. If you stop abruptly, the body can go into a life-threatening adrenal crisis.
Okay, speaking of those sores in the mouth, this is probably the single most important teaching point you'll ever give for inhaled steroids. It's so simple. After every single use, the patient needs to rinse their mouth with water, and then this is key, spit it out. Don't swallow it. This quick little step washes away any leftover medicine and prevents a nasty fungal infection called oral thrush. And you know what makes this even easier and safer? A spacer. This little plastic tube attaches to the inhaler, and it does two fantastic things. One, it helps get more of that fine medicine mist deep down into the lungs where it actually needs to work. And two, it catches the bigger droplets, so less of it gets stuck in the mouth. That means better effects and a lower risk of thrush. It's a total win-win.
Okay, so we've met the main teams, BAM and SLAM, but there are a couple of specialists we need to talk about too. These drugs have very unique jobs in managing respiratory problems.
Let's meet two of them. First up, the leukotriene modifiers, like montelukast. You'll recognize them by that leucast ending. The crucial point here, these are for long-term prevention. They work slowly. They are not for an acute attack. Then we have mucolytics, like acetylcysteine. This stuff literally thins out thick, sticky mucus. Patients might complain it smells like rotten eggs, but here's a fun fact that always pops up on exams. It's also the antidote for an acetaminophen overdose.
Okay, I really need to stop and stress this next point about montelukast. This is a big deal. The FDA has issued its most serious warning, a boxed warning for this drug. Why? Because it can cause serious neuropsychiatric events, things like agitation, depression, and even suicidal thoughts, especially in kids. So your number one nursing action is to teach families to watch for any changes in mood or behavior and to call the doctor immediately if they see something.
All right, we've got all our players lined up. We know Team BAM and Team SLAM. But what's the point of knowing all these meds if your patient can't use them correctly? Nothing, right? So this last section is the playbook. It's how we make sure the medicine actually gets where it needs to go.
So if your patient has to take two different inhalers, a bronchodilator and a steroid, there is one golden rule for the sequence. Remember, B comes before G. You always give the bronchodilator first. Think about it. It just makes sense, right? You want to open up the gates first with the bronchodilator. Then you give the glucocorticoid, the steroid, so it can travel way deeper into those freshly opened airways and do its job.
And it's not just the order, the timing matters too. There are two simple rules here. If you're giving 2 puffs of the same drug, like 2 puffs of albuterol, you wait 1 minute in between. But if you're giving 2 different drugs, like our bronchodilator and then our steroid, you need to wait about 5 minutes in between. That gives the first drug enough time to really start working.
Now, what about a real emergency? A full-blown, brutal asthma attack? For that, just remember the acronym AIM. A is for albuterol. That's your fastest-acting bronchodilator, so it goes first. I is for ipratropium, another bronchodilator that helps out. That's second. And M is for methylprednisolone, which is a powerful IV steroid to get that inflammation under control. It's last because it's the slowest. For an acute attack, just AIM.
Okay, let's put it all together. Here is the step-by-step best practice way to use an inhaler with a spacer. Imagine you're teaching your patient this. First, shake the inhaler really well. Attach it to the spacer. Then, have them breathe out completely, get all the air out. Next, seal their lips tight around the mouthpiece. Press the inhaler just once. Then, tell them to take one slow, deep breath in, and finally hold that breath for about 10 seconds. Perfect.
So there you have it. You've learned the drug classes, you've nailed the administration technique, you've got all the patient teaching points down. But here's the final, and maybe the most important question for any nurse. How do you actually know if it's working? How do you assess your patient to see if your interventions made a difference? That step, evaluation, is what truly separates a good nurse from a great one. So what would you be looking for? Think about it.
All right, let's jump right in. Today, we're putting on our detective hats and diving into the really high-stakes world of airway emergencies. You know, when breathing stops, that clock starts ticking, and every single clue matters.
It's air, that constant, unconscious process of just breathing in and out. That's the foundation of everything.
But what happens when that system gets compromised? You know, it gets blocked or inflamed or it collapses? Well, that's when it turns into one of the most critical emergencies there is. It's a flat-out race against time, where spotting the problem quickly is everything.
So, how do we spot the danger in the first place? Let's start by looking at the universal signs. The ones that tell you breathing isn't just breathing anymore,
It's become a battle.
See, your body doesn't whisper when it's starved for air. It screams for help. These signs aren't subtle hints. They're desperate moves to pull in more oxygen. Nostrils flaring open, trying to widen the airway. Noisy breathing like a high-pitched sound called stridor, which tells you the passage is narrowing. Or seeing someone use their neck and chest muscles just to pull in a breath. Those are huge red flags that someone is in very serious trouble.
Okay, so once we've spotted those distress signals, the real investigation begins. It's time to open up our medical detective's toolkit and start gathering some hard evidence.
And our very first tool is almost always the pulse oximeter. Yeah, that little clip they put on your finger, it's an amazing little device that gives us a super fast measurement of the oxygen saturation in your blood. We call it the SpO2. It's a quick, vital first clue about how well oxygen is getting around.
Now you might see this and think, okay, 95 to 100%, that's the goal. And for most people, it is. But here's where the real detective work kicks in. For a patient with a chronic lung condition like COPD, their everyday normal might be down in the low 90s. And that's a crucial piece of the puzzle. You have to know your patient's baseline to know if a number is actually bad for them.
Next up, the chest X-ray. Think of this like getting surveillance footage of the crime scene. It lets us actually see what's happening inside the chest. Is there fluid? Is there trapped air? For something big like a collapsed lung, a chest X-ray isn't just helpful, it's pretty much essential. It gives us that crystal clear picture we need.
And sometimes you need to get an even closer look. A bronchoscopy is when we actually send a tiny camera down into the airways. The prep and follow-up care here are critical. The patient can't eat or drink for several hours beforehand and afterwards, and this is the big one. We absolutely have to check that their gag reflex has returned before they have anything, even a sip of water.
Okay, so we've got our tools. Now let's line up our first set of suspects. These are the life-threatening emergencies that happen right up in the throat and upper airway.
So, meet our first culprit, epiglottitis. There's a tiny little flap of cartilage in your throat called the epiglottis, and its job is to cover your windpipe when you swallow. Well, with epiglottitis, that flap gets so swollen from an infection that it can literally seal off the airway like a cork. It's a true medical emergency, especially in children. So the clues for this one are pretty specific. The person is usually very anxious, they've got a high fever, a muffled, hot potato voice, but the number one absolute giveaway sign is drooling. They're drooling because it's so painful to swallow, they can't even manage their own saliva. And here is the most critical warning for any medical detective out there. Do not, under any circumstances, try to look in their throat with a tongue blade. That can cause a spasm that shuts the airway completely.
So how do you tell this apart from something like croup, which is also really common in kids? Well, you just have to look at the main symptom. Croup has that very distinct, loud, seal-like barking cough. Epiglottitis, on the other hand, has that telltale drooling. Being able to tell the difference is a really critical detective skill.
Okay, from the throat, our investigation is now moving deeper, down into the chest, to a really terrifying scenario, the collapsing lung.
This is a tension pneumothorax. Just imagine a one-way valve. Air gets into the space around the lung every time the person breathes in, but it can't get out when they breathe out. So the pressure just builds and builds and builds, literally crushing the lung and starting to push the heart and all the major blood vessels over to the other side of the chest.
The signs here are incredibly dramatic. The person is in severe distress. You won't hear any breath sounds on the affected side. But the smoking gun, the ultimate clue that tells you exactly what's going on, is tracheal deviation. Their windpipe will literally be pushed over to the unaffected side because of all that pressure.
All right, next up is a different kind of emergency. This isn't a collapse, it's a dangerous blockage deep inside the lung's network of blood vessels.
A pulmonary embolism, which is a blood clot in the lungs, is a huge emergency all by itself. But it also kicks off this really dangerous long-term problem, pulmonary hypertension. That blockage just causes the blood pressure inside the lungs to absolutely skyrocket.
And this leads directly to a condition called cor pulmonale. Think about it. The right side of your heart's job is to pump blood to the lungs. But if the pressure in the lungs is incredibly high, that right ventricle has to work so much harder. Over time, it gets bigger and just fails. It's a perfect, if tragic, example of how closely our lung and heart problems are connected.
So, we've identified the signs, we've used our tools, and we've investigated the suspects. Now let's wrap this all up by decoding what happens when a patient needs advanced help to breathe.
So when a patient is on a mechanical ventilator, all those alarms,
They're not just noise, they're clues. And it's actually pretty simple to figure out. A low-pressure alarm means there's a leak somewhere. Just think L for low and L for leak. Maybe a tube got disconnected. A high-pressure alarm means the exact opposite. There's a blockage or some kind of increased resistance.
And for those high-pressure alarms, there's a fantastic little mnemonic to help you remember the causes. It's 2 PB sandwiches can make you sick. The 2 Ps stand for pulmonary edema and pneumothorax. The 2 Bs are bronchospasm and biting the tube. And SCK is for secretions, coughing, or a kink in the tube. It's an incredibly handy way to troubleshoot right at the bedside. We have covered a ton of ground, from the first telltale signs to the tools of the trade. So I'll just leave you with this question. Now that you know the clues, could you spot the difference between a child's barking cough and a life-threatening drool? Because in the world of airway emergencies, being able to make that distinction, well, it can make all the difference.
You've now covered core respiratory assessment, oxygen delivery strategies, high-yield disorders, airway emergencies, and the medications NCLEX loves to test. Stay tuned. We are with you every step of the way. Our motto, NCLEX Review Pro. Prep like a pro. Let the worries go.